And welcome to our third American Palliative Rehabilitation Alliance webinar. We're very excited that you've decided to join us tonight, and we are very excited to launch this collaborative effort for all of the rehabilitation professionals and other professionals that work in this space so that we can collaborate to improve care for our patients. I'm going to pass it over to my co-founder of this organization, Chris Wilson, who will introduce our guest speaker.
Perfect. Hi, everyone. My name is Chris Wilson. I'm a physical therapist. I'm kind of co-founder of this organization. We're also joined by our two administrators, Alicia Nacarado and Jordan Cummins. They'll be monitoring the chat and then also admitting people. Since this is a webinar format, you can interact via chat, but unfortunately, you're not going to be able to unmute yourself. If you do have something you really want to say, we do have the capability of doing that, but probably at the end after the presentation's over. I'm very proud to introduce Carlos Alaniz. He's the director of Hospice for Providence Sound Home Care and Hospice. Carlos has been recognized for his achievements and contributions to advancing OT clinical practice in hospice care and advocacies for OT's role in end-of-life care. In 1989, he was honorably discharged from the U.S. Army and graduated from the University of Washington in 1995 with a Bachelor of Science in OT. He included being a faculty member and fieldwork coordinator for OT program at Lake Washington Technical College, as well as a regular guest lecturer for the UW Masters of OT program. He's been a community mentor for multiple doctorate and graduate capstone projects. Carlos's expertise comes from having worked 28 years in clinical care and having held leadership and management roles, primarily in skilled nursing facilities and hospice. And he's been the director of Providence Sound Hospice since 2020 and awarded the Providence Values and Action Award in 2022. We are very proud and excited that you agreed to present for this group, Carlos. So thank you so much for being here.
Well, thank you. And really, it's me needing to thank you and Anne for reaching out and having me speak today, and really for the work that you're doing. It's something that I've been wanting to do for a long time, and I've done my part, but I am so happy that both of you have taken the lead and created these avenues for us as therapists to explore our role at end of life. So good evening, everyone. It is 5 p.m. In Washington State. So we are just south of Seattle, about an hour 30 minutes south of Seattle. Chris mentioned that I'm the director for Providence Sound Home Care and Hospice. We serve 3 counties in Southwest Washington, including the capital, the city of Olympia. And I will start with my presentation now. The objective for today is to understand the hospice benefits. So, and I'll review a little bit of the hospice program itself and how it started. Hopefully this is not stuff that you already know. It's a fairly new program. So I know I didn't know much about hospice and how it started when I was a clinician and an administrator at a nursing home. So hopefully you'll be able to learn a little bit from that. Understand the Medicare conditional participation for hospices to provide rehab services, and to explore the model that we use here with our Providence ministries in Washington, and then recognize the benefits of employing therapists as part of the hospice IDG versus contract services. Okay. Just really quickly, hospice itself, it's a fairly new concept. It was not until like 1948 that Dame Cicely Saunders started working with patients who were terminally ill in the United Kingdom. And then not until 1967 did she open an inpatient hospice center in the UK. When the US learned about her and the work she was doing, she was brought over to do some lectures at different schools on the East Coast. There was a lot of interest here in the U.S. on what the UK was doing with end-of-life care. And in 1972, there was a hospice care hearings in the U.S. Senate, and Florence Wald, who's considered the one of the founders of the modern hospice movement in the U.S., started Connecticut Hospice in Bradford, Connecticut. And in 1972, it actually became a benefit under Medicare. And in 1986, so 4 years later, it became a permanent benefit under the Medicare guidelines. And so fairly young, right? I mean, 1986, that's not a long time. Since then, multiple hospices have started practicing and serving patients throughout the country. And there's about 5,000 hospice programs right now in the US. It is a growing market. And there's only a couple of states now that a lot of states for a long time had what we call a certificate of need process. Washington State is still one of those states where a hospice agency has to apply for a certificate of need from the Department of Health within the state to get granted a license to practice. And that has controlled the number of hospices that have started providing services in our state. But in other states, especially in the South, I know Texas, Florida, there could be about 50 hospices in one particular city. Here in Olympia, where I'm at, we're a smaller city. There's about 5 hospices that are serving patients right now, serving our communities. And in Seattle, I want to say there's about 8 hospices serving the community. So if you compare that to the other states, it's certainly significantly different. The understanding of hospice, of course, it's there is no cure. The focus is caring for the person and the family at end of life. The goals include control of pain and other symptoms by meeting not just the physical, but also the psychological, social, emotional, and spiritual needs of the person, but also the family. And that's key as we talk about hospice, right? We are treating the patient, but along with the patient comes the family, the caregivers who are caring for that patient. It is important for us to provide services to them as well. And we do that in different ways, and I'll talk about that in a little bit. Just a little bit of information on who qualifies for hospice. So patients have to have a limiting illness with a prognosis of 6 months or less to live, as determined by 2 physicians. That's usually the referring physician. Let's say it's the patient's primary doctor, the PCP. And then the second physician would be our hospice provider. We have a medical director in our program, in all the hospice programs. And then there's other doctors that are part of that team as well. So there's no 2 outside physicians. It can just be like, let's say that the PCP, it can be the oncologist, it can be even the hospitalist at the hospital where maybe the patient was initially when the referral to hospice came to be. And then the second physician can be one of our hospice physicians. And then patients must be recerted for eligibility at a regular interval. It is every 3 months for the first 6 months. So patients get admitted. After 3 months, they have to be recertified. And then at 6 months, they have to be recertified again. After that, it's every 2 months. One thing to note, and this is why any person you talk to who works in hospice right now will tell you that we don't serve the community that we should be serving, or the whole community that we should be serving. Only 48% of Medicare recipients utilize hospice care when they die. So anybody 65 or over, or anybody also qualifies for Medicare, only 48% of them use hospice at end of life, which is quite significant. the National Hospice Associations have been trying to move this number a little bit up. And actually, it decreased a little bit. It was more like 50%, 51% back in 2019, and it decreased by 2 or 3 percentage points in the last couple of years. Significant because we want to make sure that patients receive that benefit. It's something that they paid into, and it's a free service. It's hospice is paid entirely by Medicare. There is no copay to the patient, and as we'll talk about later, you'll see there's quite a significant number of benefits that the patient gets when they sign on to hospice. Where do we see patients? Anywhere, really. I listed a whole bunch of places here, but it's really anywhere. I would say that in my ministry, and we call them ministries here with Providence because we are a Catholic-based organization. So any service that we provide, whether it's a nursing home, the hospital, assisted living, we call them ministries. But about 50% of our patients live in their private homes. About 50% live in congregate settings, let's say an assisted living facility, an adult family home, or group home, or a nursing facility. But we've served patients who are homeless, patients who are in temporary housing or are in shelters as well. And who makes up the hospice team? So of course the patient, the family and the caregivers, and then the primary attending physician, their PCP. Usually, there are times that the PCP will request that the hospice medical director takes over the care of the patient while they're on hospice. Or sometimes, like I said, they may have been referred to us by a hospitalist. The hospitals, the patient ended up in the hospital. It is determined that they are at end of life, and they go home and they get admitted into hospice. So especially in those cases, the hospitalist will not most likely be the attending for the patient or the primary. They don't have a practice outside the hospital, let's say. So our doctors within the hospice team also can become the primary and the attending physician for the patient, and that's more common nowadays. Actually, more PCPs, more doctors would just rather leave the hospice care and care coordination to the hospice provider. And then of course, very focused on nursing care. We have the RN case managers who manage the nursing care, but also the entire care for the patient throughout, the day, Monday through Friday. And then we have, of course, evening, night shift nursing available. We have medical social workers, hospice aides or CNAs, and chaplains. In our case, some agencies have spiritual counselors, and volunteers. And volunteers actually is a requirement by Medicare, because hospice started as a volunteer service back in the history that I was mentioning. People who started providing hospice services in this country were all volunteers, nurses, doctors, chaplains, social workers. They were all volunteers. So when the law was implemented in '82 and then adopted permanently in 1986, there's a clause in there that 5% of the hours of care provided to a patient have to be provided by a volunteer, which they just wanted to keep the benefit true to the original thought of hospice and the community pulling together to provide services and support for the patient. So it doesn't mean that every patient gets 5% of the hours for their care by volunteers. It just means as a whole. So we have patients who do not get volunteer services. They decide not to. But then we have other patients who get more than maybe, let's say, those 5 hours or the 5% of the hours. And then of course some comfort therapies, massage therapy, music therapy. And really the hospice team should also have an OT a PT, and an SLP. Who pays for hospice care? Primarily Medicare, but as we know, what Medicare does, other insurances do as well. So in those states who have Medicaid, Medicaid pays for hospice care as well, and then private insurance does as well. But I would say maybe about 80% of the patients we serve in our area are Medicare eligible. There are patients who are younger and may not qualify at this point for Medicare. Then their private insurance will pay for their services. I actually haven't experienced a case where someone pays privately. There's always a way that our team finds for someone to pay for the hospice care that the patient is receiving. We do, however, within Providence, our Providence health system, we have charity care, and a patient is able to qualify for that depending on their resources. We actually have a patient who we are providing care right now through charity care and started receiving charity care through our local hospital, also a Providence hospital, and then went to a nursing home. And it's actually still at the nursing home, and we're providing care while they're at the nursing home for hospice. The hospice payment. So Medicare pays hospices on a per diem rate. The national average of the daily rate is about $181. So it depends on whether on where you're at in the country. Let's say probably Providence Hospice of Seattle gets a little bit more than we do down here in the Olympia area. But like I said, the national average is $181. But Medicare pays that payment, that daily payment, regardless of the number of services being provided on a given day. We may have a patient in our services, and a nurse is visiting twice a week. Chaplain is visiting once every 2 weeks, a social worker once a month. A bath aide or hospice aide maybe is providing visits once a week, sometimes 3 times a week. But a patient may not get services on a particular day. That does not matter. We are providing other services. And so Medicare gives us that reimbursement daily. And it should cover all the cost for the hospice to provide whatever the patient needs. So this includes medications, DME, and medications. For a long time, it was really just based on the patient's diagnosis, but Medicare has been asking hospices to provide coverage for more and more medications. So it's rare that there are medications that are not covered by the hospice. Medicare finds a way of finding that a medication is related somehow to not just the hospice diagnosis, but anything else that the hospice diagnosis also may be contributing to. And DME, an adjustable bed in the home, a wheelchair, a walker, bedside commode, shower chair, Hoyer lift if needed. Here with Providence, we are very lucky, and I think especially because of the work that the OTs have done, and I'll talk a little bit more about that. We've advocated for a lot more than what most hospices provide around the country, or even our competitors here in our area. We provide things like a tilt and space wheelchair, or like a Broda chair. We provide sometimes a power Hoyer lift. We provide now the four-wheel walkers with a seat in the basket. There are things I think that we've been adding to the list of things that we provide. As we get patients who may not be, our goal is to admit patients when they need us, right? And the sooner they get to our services, the better, because we're able to provide a much better care when someone is not just on our service for 3 days or a week. Our goal is to, just like I was saying earlier, the National Hospice Associations, they want to serve as many patients as possible, but also for a longer time. We know that we can serve a patient better and a family better when we have them under our service for 60 to 90 days. The hospice also provides supplies. So these are supplies that are used for bathing, for skincare of any kind, whether it's wound supplies or prevention, lotions, creams, barriers, briefs if the patient's incontinent, shampoos, um, tothettes, for mouth care, those kind of things. And palliative treatments as well. So depending on the hospice, right, we want to make sure that the patient is gonna have it will be pain-free or symptom-free. So right now, actually, we're admitting a patient tomorrow who we've approved to receive 10 radiation treatments to minimize the size of a tumor that is impeding her breathing. So there are times that a hospice may decide to cover something for the benefit of and quality of life for the patient. We also provide bereavement services after the patient passes. So there is spiritual care, like I was saying earlier, for the patient, for the family while they're on service. Anticipatory grief can be addressed by our social workers, by our chaplains. But then as part of the hospice benefit, the family is followed by the bereavement team for the hospice for a year after the patient passes. It's a wonderful service. Here in our ministry, we provide not just individual counseling, but we also provide events. We just had an event a couple of weeks ago on grief in the holidays, where our bereavement counselors provide tools for families who lost a loved one, especially as they are approaching the holiday season. And then, of course, under the hospice payment, all clinician visits are covered, and including rehab therapies. And that's where the issue lies. So the condition of participation that talks about rehab services is 418.72. It says that PT, OT, and SLP services must be available and, when provided, offered in a manner consistent with accepted standards of practice. So again, a very very poignant guideline to tell hospices that they should be providing PTOT and speech when those services are needed. So who pays for therapy services? Well, like I was saying earlier, it's the hospice. They get that reimbursement, that per diem rate, those $181, and from that money, they should be able to provide those services to the patients, just like they do the nursing visits and the hospice aid visits and the chaplain visits, or that medication or that piece of equipment. There are some ministries or agencies, I should say, and I'll talk about our example here with my ministry. We use the foundation for the initial startup of our OT in hospice program. And I can talk a little bit more about that. I know that there are VAs around the country, and I know for sure the one here in our Puget Sound area, they do approve for some therapy visits once the patient is enrolled in hospice. I used them in the past when I was a clinician in the field as an OT. There was something that maybe the patient was already working on with a therapist in the hospital or in the community in home health. And so I would get the therapist to come in and jointly do treatments or provide services to that patient. So how do hospices meet that condition of participation? Well, a few hospices have a combined home health and hospice model. I met a few clinicians out there in around the country where their nurses, their social workers, their team sees home health and hospice patients, and that's part of their caseload. They may have a handful of home health patients and they have a handful of hospice patients. It is rare though. I do meet most people who work in settings where home health is separate. Um, a handful of hospices do have a therapist on staff, and through the work that I've done, um, or people that I met in conversations that I had about this topic, there's some people, some therapists who do work in hospices, and they're embedded within that hospice program, which is great. Oh, someone's asking. I don't see questions. Oh, maybe I can pull it up.
I have a question from that somebody put into the chat, Carlos.
Yes, go ahead.
So Julie Groves, occupational therapist, she asked a couple of questions. The first one is, are you getting patient standing lifts covered?
No. Well, I mean, so it's up to the hospice, right? It's up to the hospice. Our hospice here, we have said no to stand lifts, but we do say yes to Hoyer lifts. And we say no to standing lifts because we believe that our patients can change significantly from one day to the next, or even from the morning to the evening. And we provide a Hoyer lift because maybe they are bed bound and they need total assist to be transferred from the bed over to, let's say, a recliner or a broader chair. But a standing lift or a sit to stand lift, it's a little bit more complicated for us to be able to manage its use in the home.
Thank you. And then she had a couple of others as well. So the second one is, do you have data to help us encourage our DME companies to carry them and the hospice to add them to their formulary?
I am working with another doctorate student who's starting next month with me, and we are building some data on this and other things too, and hopefully be able to provide that information once it's done via maybe this group itself. Yeah, for us here in our ministries, as OTs, we've been able to advocate with our leaders about, here's the benefit of a broader chair that is, you are able to admit a patient who may not be quite at end of life, but they do have that 6-month or less prognosis, who lives in a facility and who's still interested in attending meals, or go to the dining room and attend activities in the milieu, in the environment where they lived for the last 5 years, right? Just because now they're on hospice and they're weak and cannot sit up in a standard chair, they should be secluded in their room for that reason, right? So through those means, we've been able to advocate for those things, for that DME, including the 4-wheel walker. For a long time, we provided a front wheel walker, and we proved to our leaders about the benefit of a 4-wheel walker, and now we're able to provide that.
Thank you. That was the last one.
Okay. Yeah, please keep them coming and stop me, because I can just continue on. And some other hospices have a contract, and that's usually what I see out in the different parts of the country, where a hospice will say, well, I have a contract with a partnering home health agency, and when we need services, then we just reach out to them. And that's actually what we had here in our ministry when I came and I got hired as a director. Within Providence Health System here in the West Coast, we have about 15 hospices from Lubbock, Texas. There's one in Lubbock, Texas, throughout California, Oregon, Washington, and Alaska. And I was employed 18 years ago as an OT with Providence Hospice of Seattle. And I did that work there for many years. And eventually, our sister ministry north of Seattle in Everett, Washington, they hired an OT. For some reason, the ministry down here in Olympia, the leader at that time did not just thought that maybe this home health partnership was good enough. And that's what they did for many years. When I came on board as a director, and because it was one of my goals as an OT, being in this role, to do what we did in Seattle and to do what we did in the other ministry north of Seattle. So I started looking at how long was it taking for a referral that we sent to home health to be addressed. And because, and I'll share at least one story later on, towards the end of my presentation about, what changed for me and why 18 years later as an OT, I'm still doing hospice work. And one of those reasons is because if you have an OT or a therapist embedded within your hospice team, they'll be able to see the patient quicker. Again, I'll share one of those stories on why it is critical, and we cannot wait 7 days or 5 days for a home health therapist to finally find room in their schedule to go see this hospice patient. But also, I was reviewing some of the assessments that the home health therapists were doing, and there were great assessments, but it lacked the focus on end of life and quality of life. Maybe the referral was sent because maybe the patient expressed desire to transfer out of bed, and they would do transfer training, the therapist from home health, but they didn't link to, well, why does the patient want to get out of bed? What is meaningful in their life that they want to get out of bed? And so that's where I was able to justify that we needed a therapist embedded within our hospice team. And as of this last April, we were able to hire a full-time OT to be part of our team. And unfortunately, I do know, and I cannot tell you who, but I hire a lot of nurses, a lot of other clinicians who end up working for our ministry here with us. And when we talk about, they go through orientation and they get to meet the OT or even shadow the OT. They're surprised that there's an OT as part of the team, and these are nurses who came from other hospices, not just around here, but hospices throughout the country, or even travel nurses. We have 2 travel nurses right now who both of them said, "What do you mean you have an OT?" And so that tells me that there are hospices who either may have the contract with a home health agency but don't use it, and they don't let their staff know that therapists are available, and that they have access to for their patients to refer to. So a little bit about the history of OT at Providence Hospice of Seattle, and that's where it all got started. And when I was preparing for my presentation, I talked to Anne about, what I know is what we've done here with our Providence Hospice Ministries in Washington. I know that there's a benefit to all therapies to be represented at end of life and provide that essential care to our patients. But I just wanted to talk about what I know, and what I know is about the role of OT in hospice. And back, back in the late 1980s, the director of the hospice of Seattle started wanting to abide by the regulation, and he knew that therapy service had to be included as part of the benefit and the care. So and this is what I know from the therapist who I replaced in Seattle, and who was retiring, and who had been one of those first initial therapists to be hired on to the team. This director assessed, what the needs were, and he determined that it was difficult for him to justify hiring an OT, a PT, and a speech therapist. And through the work that he saw them do, realized, well, maybe I'll just hire an OT who can maybe address some of the other things that maybe a PT or an SLP would address at the basic level where a patient's may be at end of life. An OT can address those things, and we can certainly talk about a little bit. We can talk a little bit more about that a little later. So in 1992, here with Providence Hospice of Seattle, the first OT was hired. Eventually, I became the second OT hired, and then we eventually had a third OT with Hospice of Seattle. And then, like I said, the ministry north of Seattle hired their own, and then now, as of this April, we have our own down here in our Southwest Washington area. And I prepared a presentation many years ago for the Washington Hospice Association conference, and in doing the research, at that time, this is one of our mottos, one of our logos for OT at AOTA, Occupational Therapy, Living Life to the Fullest. And at the same time, I found this statement with Providence Hospice of Seattle. It was on our website, and it was on all of our material. It talked about hospice care is about living its quality of life, personal choice, and compassionate care. It's about making the best of all of our days, of the days you have left. It's about finding comfort in company and relieving suffering and pain. Hospice is about living life to the fullest. So OT, and again, talking about what I know, what we've done here and for many years, but the 18 years that I work with here at the Providence Health System. OT recognizes that continued participation of daily activity or occupations may serve dual purpose for hospice patients. Occupations may provide a means of self-expression and engagement while also serving as a vehicle by which a patient finds peace with the dying process and prepares for death. So I talked a little bit about this earlier, about the story of the director back in 1992 deciding who to hire. I cannot hire all three. There was a small program, and so OT is a holistic approach that focuses on the whole person. We address mobility, cognition, communication, eating, feeding, and swallowing, ADLs and IADLs. There's questions a lot about, well, how do you address swallowing? Again, at the basic level, where most of our patients are at end of life, an OT can educate a patient, a family on safe swallowing protocols, like sitting upright, chin tuck, just several strategies that we do, right? I mean, OTs work alongside the SLPs, let's say in other settings, a nursing home and a hospital, and the OTs working on self-feeding, while the SLP is working on swallowing. But there's some knowledge by the OT on safe interventions for safe swallowing as well. So in collaboration with our IDG team or IDT team, support continued participation in meaningful activities and roles, provide caregiver training on positioning, transfers, patient safety, teaching energy conservation, pain management strategies, task modification, address adaptive equipment and DME needs. And in general, and I'll tell you that our goals for as OTs when we go see a patient, our goal is to maximize patient safety, comfort, and quality of life through meaningful participation in occupations. And really, when you go see a patient, and I've been doing joint visits recently, we have our part of our annual competency evaluation of our therapist. We do supervisory visits, and I've been doing those before the end of the year. And And yeah, and that is our goal. That is our goal, and that's, we don't have any other goals like we do in a nursing home or in home health. Our goal is to maximize patient safety, comfort, and quality of life. Sometimes you get a referral from a team member, from a nurse, let's say, who is talking about, patient is at risk for falls because they have a cluttered environment, and you go there and you will certainly address that. But there's also you may identify, or the patient may identify other reasons for OT or therapy interventions. Other benefits of therapy services: so prevent family caregiver injuries. That's really one of the main things that we do. We end up having family members who have never cared for an adult person before, and now their loved one is in their home, and they're needing to provide care, whether it's transfers in and out of bed, to showers, or help with toileting. So providing a lot of caregiver education is a focus of ours. Reduce patient falls. We have a fragile population. We have a population of patients who is using some opioids and other medications that may create a greater risk for them to fall. So try to mitigate that. Try to provide some interventions ourselves through function to reduce those falls. We may have patients who are bedbound or chair-bound, and can provide pressure relief for themselves, or their caregivers cannot. So how to provide interventions, education for those caregivers, but also some DME as well. We're lucky, again, in having been able to advocate for our patients, and we have low air loss mattresses, alternating pressure mattresses as well. And eating, feeding, swallowing strategies, like I said earlier. There's a comment in the chat, and I don't see the question. Can anybody read it?
Those might be me, Carlos. I put in one. We're going to do a little presentation or update on some new billing codes coming up for caregiver training for non-hospice patients. So
great. Okay.
Yeah. Thanks.
Yeah. You're welcome. And some of the work that I'm doing right now too, because now that I got got an OT hired within our program, and I was saying earlier that we have ministries from Texas all the way to Alaska. Well, Washington is the only state right now that have hospices with Providence who are employing OTs. So I know that we have meetings with other directors, other leaders within the other states that we serve, and they're interested in how they can get what we have up here down where they're at in Oregon or in California especially. So some of the work that I've been doing and that I'll be doing with a student that starts this January, but hopefully another one later on in the summer. What are the benefits? What are the other operational benefits? Do we have less injuries to our staff, because now we have an OT who can go out with a hospice aide who is saying that this patient wants to continue having a shower, but they're finding it difficult to get him transferred into that shower or to the bathroom. The OTs here participate in a skills fair for the nurses and our hospice aides. And like I was saying, doing joint visits with staff, especially with our hospice aides who may be encountering some challenges with mobility, with function of a patient. And right now, one of the things that I just finished creating was a brochure to market to our facilities here in our area. Another reason why we are different than our competitors. We have an OT that's embedded within our hospice team. And also one of the things too, maybe through therapy services, because we're providing that education to the patient, the family, keeping the patient safe in the home. and maximizing the quality of life. Maybe we have worked with a patient now where they're able to be out of bed in their environment, and they're living a better quality of life than they would have been if they had stayed bedbound. And so maybe we are increasing the length of stay. I talked about how it's important for us to have a patient in our services for them to really maximize the benefit of hospice, for them to be with us for 60, 70, 80 days, or even longer if all possible. Our average length of stay, usually the national average is about 65 days. The median length of stay is about 17 days. And we want to increase both of those. Like I was saying earlier, the hospice benefit is, you have 6 months or less. So we do have to recertify someone after 3 months, and then again after that 6 month, and then every 2 months after that. But we've had patients in our service who have been with us for 8 months, 9 months, even a year, or even longer. Sometimes a patient, let's say, with a patient with ALS, certainly a patient with MS, who come onto our service, they're not doing well, but through our services that we're providing, they stabilize a little bit. We can justify to Medicare that they are still declining in their function, declining in maybe their weight as well. But hopefully through intervention, especially from a therapist, we're also allowing them to maximize their last days of life and their a little longer, and creating not just a benefit for them, for their families, but also for the hospice agency itself. And just really quickly, the story that I wanted to share that talks about why it's important to have a therapist as part of the team, right? And because someone can be out there sooner than later. Let's say if you don't have that therapist as part of the team, maybe you're referring to that home health agency that you have a partnership with. But earlier on in my hospice career, I was doing my orientation, my first 2 weeks of orientation. I was shadowing other clinicians, learning what my role was going to be and what their role was as well. So I shadowed a hospice aide, and we got to a patient's home, and this patient had just been admitted. The hospice aide was there to provide a bed bath. The patient was bedbound, and she introduced me. The patient looked at me and said, "Can you get me out of this effing bed?" And he did say that. He said, "I've been in this bed for a long time now. My doctor said that I can't get out of bed because I have a risk of fracturing my hip." He had lung cancer with mets to the bone, and he said, "But I don't want my wife to continue having to toilet me while I'm in bed." And so anyway, I couldn't do anything that day, but I was released shortly after to do my OT work out there, and I was able to see that patient and talk to the patient about the risk, talk to the doctor about the risk, and the doctor said, the patient can make his own decisions, right? And that's the wonderful thing about hospice. You educate about risk, and then the patient, if they're able to make a decision, be able to decide, yes, I want to do this. Just like with a patient who cannot, maybe the hospital recommended putting thick liquids, and the patient goes home and says, "I don't want to drink my coffee with a spoon," educating them, right, and allowing them to make those decisions. So this patient said, "Yeah, I'm aware of the risk." So work with the patient on sitting at the edge of the bed, scooting alongside the edge of the bed, and then brought a transfer board and a drop arm commode. He was able to go to the bathroom upright for the first time in a few months. It made a difference in his last few weeks of life. I didn't share this with you earlier. I talked about my 18 years in hospice. My first day was Halloween day of 2005. I told myself I still didn't know what I was getting into. I went to the hospice ministry in Seattle to interview for a volunteer director position. And they looked at my resume and said, "You're an OT? We're hiring for an OT." I never thought I could do OT work, just like many of us, hospice work, sorry. I didn't know I could do hospice work as an OT. Like many of us as therapists out there right now don't know that we can do this work. Anyway, so I told myself on that first day, it's either going to be a trick or a treat on Halloween Day. Well, 18 years later, I can tell you it's been a treat. And that experience, the first couple of weeks of my work in hospice, really shaped my personal journey through my work in hospice care, but also my personal life as well, and making my decisions, my having a plan for what I want. As I, if I ever get diagnosed with something that will shorten my life, or when I die of old age, it has prepared me well for that, and in turn, I've been able to prepare my loved ones for the same. And how can we do this work? It's a question that we get asked all the time, even from therapy colleagues that I work with in the past, at the nursing home, let's say, or maybe my classmates from OT school who say, "How can you do that work?" And I say, I do the same work you do, but the patients may only need those skills for a week or a day, sometimes just a day. But sometimes even for months, but how meaningful it was for them. This patient that I talked about, that I shared this story about, he lived for about a month, because I remember another difference that we were able to make in his life was that he was able to sit upright in a wheelchair and have Thanksgiving dinner with his family one more time. So I believe he died either the end of November or the beginning of December. But keeping those stories in my head and in my heart keep me wanting to do this hospice work until I retire. Because as therapists, despite the fact that these patients are dying, you can make a huge difference in those last few days, or last few weeks, or last few months of their life. And just to close, this is a reading that I like to do often when I present at the local therapy programs for their students. Hospice is not about dying, it's about living until you die. And did you get what you wanted from this life? Even so, I did. And what did you do? And what did you want? To call myself beloved, to feel myself beloved on this earth. There's some references on here for you guys, and you can share this PowerPoint with attendees if you like.
Thank you so much, Carlos, for your time and for your passion for this work, and for all the patients you have served in the past 18 years and beyond. We appreciate it, and I think we all wouldn't be here if we didn't know how important it was for all therapists to be in this space. And we just thank you for your time. We know it's hard at 5 o'clock at night when you're wrapping up work. So I did put in the chat, we're going to try to take some questions. So if anybody wants to throw some questions in there, Jordan and Alicia will look at those. I did want to say two things. One is that the AOTA, we are starting a community of practice for palliative rehabilitation, and that's going to launch on January 22nd. And then, Chris, do you want to share the slide about the CPT codes? Okay, I will.
Sure will. So in just a second, you should see my screen. Can you see it, Anne?
Yes.
Okay. So this is actually from the APTA, and I will put this in the chat, but I'm hoping the other professional associations also have this, is there are new caregiver training codes available. So I put that into the chat, but here is the slide that really kind of gives you a quick brief about it. Starting on January 1st, and this is for probably patients who are in palliative care, not necessarily hospice, because as Carlos clearly illustrated, the hospice is on a per diem. So really for both all PT, OT, and speech, there is a new code to train caregivers, even if the patient is not there. So training them on things like how to use a Hoyer lift, swallowing, ADLs, IADLs, problem solving, safety practices. So all the things we need to train the caregivers in, even with the patient not there, there is a code for that. So the initial new code is 97550. We have no idea how much each insurance company is going to pay for or not pay for these codes. But my opinion is we need to use them to show that they're important. And then if you do go beyond 30 minutes, there is a new code 97551. So you'll list 97550 first for the first 30 minutes. And then after that, for each additional 15 minutes, you bill 1 unit, 2 unit, etc., depending on how long you're there for. There is a 97552 with multiple sets of caregivers. Right now, the CPT definition does not clarify an amount of time for that. So that's still to be determined, but that is happening starting in less than a month, that these codes will be available. And we'll have to check with insurance companies to kind of start working through that. Again, I shared with you what the APTA said about that. We do encourage anyone to ask any questions of Carlos or anyone on the group here. While we're waiting for people to kind of go through their codes, I do want to let people know that we do have a American Palliative Rehab Alliance website. If you have not visited it, or if you know of someone who is not a member yet, they can click there to register for this upcoming event, or just simply register for our mailing list or newsletter, and follow us on social media. We have lots and lots of resources, including this future presentation will be under past events and recordings. So if you want to see the recording, you want to share it with any colleagues. I agree with Carlos. I think OT is an excellent, logical person to be in hospice. I've kind of said in my hospital setting, we do inpatient hospice, that OT should be a standard order for every single patient who is enrolled in hospice, because maybe they don't need physical therapy anymore, but they still got ADLs to do, and they still got functioning and tasks to do. So sorry for any PTs, it's not a betrayal, but I think it's really important that occupational therapy is, because they can speak to cognition, swallowing, positioning, and then loop us in as needed on the other disciplines for some of those more complex cases. So I thought that was a great and very innovative strategy. So I will stop sharing. I'm not necessarily seeing any questions in the chat, so you must have answered all the questions, Carlos. Good job.
I will say, Chris, that thank you for bringing that up. In my years of practice as an OT in hospice, I have reached out to the PTs and SLPs within our program, our home health program. And in one case, I did a joint visit with our SLP. I was seeing a patient with Parkinson's for swallowing, and it was beyond my scope. It was beyond that the basic education, right, for that patient or for the caregiver. So the SLP was there with me, and was able to provide further interventions.
Yeah, and I really like that model for some of those basic patients. But I think there is also opportunity. The per diem is there. It's good for what it does, but it is flawed when it comes to rehabilitation to a certain extent. So I think there are opportunities to advocate for our legislators and our insurance companies to update and modernize the hospice per diem a little bit to be more inclusive, because I think that is one of the challenges of the per diem is, if you have PT in there, if you have OT or you have SLP, it's great, but now there's a hunk of the pie that isn't being available for basic services.
Mm-hmm.
And I think that is a problem. If the patient gets PT, they can't get their DME, or they can't get home health on that day, or whatever service there is. So it's not a perfect system. So I like the innovation that we have, but certainly we'll continue to advocate. And maybe this organization is the one that should be starting to have that conversation with Medicare. So so that's all that I have. And do you have anything else?
I guess we're all going to Hospice on the Hill next year then, huh, Chris? Is that what
That's
we're going to?
right. Let's go advocate.
I have had more than one hospice director tell me that there's no money for therapy.
Mhm.
So I appreciate what Carlos does, because I know in my bones that it's not just something that's wanted, it's something that's needed. And we appreciate your time, Carlos. We thank all of the participants for joining us tonight. And we ask you to just spread the word about this organization and about the need for the growth of palliative rehabilitation. Thank you, everybody. Good night and have a great new year. We'll have
Thank you.
another
Thank you.
speaker coming in February to be determined.
We'll see you in
Thanks,
February.
Carlos.
Thank you.
everyone.
Bye-bye.
Bye-bye.
Thanks, Carlos. Good job.